FAST, so extended focused assessment of sonography and trauma. It traditionally, before the E part, was the four views down here on the bottom. So that's your right upper quadrant, your left upper quadrant, your subxiphoid, your suprapubic, and then we've now added the two anterior chest views, looking for pneumothorax. Keep in mind that this is all based on the flat, yeah, go ahead.
Should we ask questions as you go along?
Yeah,
That's
yeah.
relevant to what you're talking
Absolutely, yeah.
about? So, because I just took part of an exam, and the new thing that I was exposed to for the first time was ultrasound for pneumothorax. And I was like, where's the chest x-ray selection? And so is this replacing that? Is it going to? Is it heading that direction?
Well,
or are you just going to stick with, I mean, if you have an ultrasound and you can see whether it is or isn't.
So to be honest, the ultrasound.
You don't get the whole lung in it, but like.
So there's a couple caveats to that. Okay. So it has been studied. There's many studies that actually compared chest x-ray to lung ultrasound, not just for pneumothorax, but for other pneumonia, etc.
Like
and the sensitivity specificity for ultrasound is very, very high, above 90%, both sensitivity and specificity in studies. Now keep in mind, they're small studies, people who are highly trained doing them. As far as we're looking for pneumothorax, we're really looking for clinically significant pneumothorax on the lung ultrasound. We're also making an assumption that this patient is lying flat. So this is your flat trauma patient. Air rises, so you're only looking at two spots here. You're just looking at about the second or third intercostal space on each side, just one view.
Sorry. And the truth is, if
just
they
one view.
Have it, you're going to put a chest tube anyway. But this is just
correct.
Okay, all right.
The chest x-ray takes time. You got to move everybody out. You got to position the patient, especially if they're unstable. You suspect pneumothorax, you can get your answer pretty quickly. Yeah, it's actually very easy to do, and I'm gonna. Sorry, I won't touch the screen anymore. I didn't know it was a touch screen.
Well, you can go next slide.
Next slide. Okay, interesting. Anyway, it is very good. To be honest, it probably won't replace the chest X-ray anytime soon. I think we're more comfortable with chest X-ray and all of that. But like I said, in somebody who is unstable, who you don't want to wait for X-ray, it can be very useful and it can be very accurate. Okay, so those are our 6 views. Moving on, so where did this come from? So this has been around a really long time. This study was put out, and this is kind of Grace Ruzicki is kind of the founder of FAST, and this was put out in 1995. So it's been around for almost 30 years now, mostly in Europe and kind of trickled into the U.S. So this is something that's pretty much the standard of care that we need to kind of get on board with. Why we're doing this as well as I'm sure you know, we were kind of cited by the American College of Surgeons on our last visit that we weren't really doing FAST when they were indicated and nobody was reviewing them. And so anyway, this has been kind of an initiative to get this up and running as fast as possible.
Need a password.
So, all right. So anyway, it's something that we're working on. I'm working with Dr. Coletti and the ED administration as well to sort of get this up and running. Right now we're working on a process where you can put an order in an Epic and then pull the order up on the ultrasound machine, which will pre-populate the patient's information. You can do the FAST, you can send it to PACS, and now it'll be uploaded to the patient's chart essentially. And then you can document, positive, negative, and then it can be reviewed by basically me at the trauma reviews. Every month.
Well, let's start around this. I guess I got to ask a question. So, I remember when I was in trauma as a student in rotations back in 2009, 2010. There was this kind of notion that in like a normal intensive patient, the FAST exam would then have a high level of sensitivity for free fluid within the abdomen. So they're saying that if it's a high level trauma comes in as level 1, why waste the time? Why just skip right to the CT scan and don't waste the time on the FAST?
So you're 100% right. A lot of what I'm going to talk about. So first of all, just my personal feelings on the FAST. This is sort of sidebar. Is that the FAST kind of sucks, to be honest. It's a very hard scan to do and to do correctly. It has its role. It's very useful. but it's for a certain, patient.
Yeah.
The patient who's unstable, who you can't get to CAT scanner,
Yeah.
who you want to know is there intra-abdominal free fluid, is there a pericardial effusion with tamponade, and you want to go and take them straight to the OR without CAT scan. There's a couple other indications that we have here, which I'm going to talk about with our protocol here, and that's like if you want to rapid transfer somebody to Hartford without the CT, which we've been doing a lot of, I think. You like skip the CAT scan, we're going to Hartford because of, let's say they have an open femur fracture, or something like that, which I actually had a case not too long ago, and it was just, let's just scan them.
Yeah.
They were stable, let's go, but you want to make sure that they don't decompensate and die en route kind of thing. So that's another indication. Penetrating trauma, if you have someone who's stable, it can be useful, especially the cardiac view, to make sure you don't have a pericardial injury. So anyway, to answer your question, it has its role, and there's a lot of cases where you don't need it, but it's highly operator dependent. So the more we do, the better we get at it. When we actually need it, the more comfortable we're going to be with actually doing the scan.
I've tried to make an argument for a long time. We're wasting time with a lot of our fast scans on patients, and you're like, well, it's first step, and I'm like, no, it's not fair because I wrote my thesis paper on the fast on blood abdominal trauma, so I knew like the statistics.
So you can teach this. You got more experience probably than I do.
No, I don't have that much experience like actually performing them, but yeah, when I worked at University of Texas with their trauma team down in Houston, we just straight to the
100%. If you can get the patient to CAT scan, that's what they need. But we had the same sort of thing where I trained, and it was always kind of a question of whether or not to do it. The bottom line is that it's a skill that if you don't learn or you don't practice, you don't get good at it when you need it. And then you start missing. There's a lot of misses and all of that. So Dr. Coletti wants us to do these as much as possible so that we get the practice. But we shouldn't be delaying CAT scan to do this.
Yeah, I guess the reason why I was wondering is because we got dinged for not doing them, and I'm like, well, what if the data shows that it's better to bypass and go straight to a CT scan, like on like the stable patients or like the high level traumas, then why are we getting dinged on it? Is kind of what I was wondering.
Part of that is their guideline, as I'm sure you know, but it's always in hindsight because we've had cases, from what I'm told, we've had cases where people have decompensated in CAT scan or shortly after CAT scan over the last 10 years that have decompensated shortly after CAT scan and were trying to be resuscitated in CAT scan, or they had to be rushed back to be resuscitated, and it was kind of like, can we prevent that from happening? And maybe we should be doing a fast before the CAT scan. That's sort of historically, but mostly it's because we're told by our accreditation body that we have to do it. But I agree. I fully understand that there's a lot of problems with it. And I'm going to talk about a lot of these problems too. So these are our guidelines. I want to really just point out the first three, which I did again. These first three are what I was mentioning before. So blunt trauma with unstable vitals, stable penetrating trauma, and then anyone who you're going to rapidly assess and rapid transfer to Hartford without CAT scan. And then we'll talk about some of the other ones in some other slides. So how much fluid can we detect? The studies show in the abdomen about 200 to 250 cc's. A lot of that though is operator dependent. The better you are at doing it, the less you're going to be able to see. And thorax is about 100, and cardiac is about 20 to 25 cc's. But really, when it comes down to it, when they're unstable, you're probably going to see it. It's going to be very obvious, and I'll show you some very obvious ones. The sensitivity greatly increases when you get over 600 cc's.
Not like because I guess you could have like 250 diffusely and probably not notice it, but is this like more like a focused area? Like
this is when they did a fast, and then the patient went to the OR, and then they found out how much blood was there. So you kind of have to take it for what it's worth, or there are studies where they do CAT scan, and then you kind of try and quantify it. But you're right, that's just a total amount of blood in the belly.
Now you're talking about blood, not like
Or
suckers from the bowel?
So we're talking about just free fluid.
Okay.
Right, which could mean ascites in someone who's a cirrhotic as well. Again, we'll get there. So there's a lot of limitations. Not all free fluid is blood. So you have a 20-year-old who's hit by a car and he has no medical problems, and you do a fast and it's positive, it's blood. But if you have, a young female, let's say, it could be physiologic free fluid. If you have someone with ascites, it could be just regular ascites. It doesn't necessarily have to be blood. There's no way to distinguish that on ultrasound. I put roll for DPL on here. I did talk to Dr. Coletti about it. He's for it. He's all about it. And some of the trauma surgeons where I used to work was all about it as well. I know it's kind of gone out of favor, but if you have a patient who is a known cirrhotic, who has abdominal pain, maybe quasi-stable vitals, like they're systolic 90, but maybe they live at 90, even a DPA, just an aspirate to see if it's gross blood versus just ascites, there might be some role. It's a little bit controversial, and it's going to depend on really the surgeon, but that's an option here. There's lots of false positives. The bowel, especially the fluid in the bowel, can look like it's free fluid depending on how it's positioned. The blood vessels, the gallbladder, cysts on the kidney, on the liver, and then, not all pericardial effusions are blood. They might have been there as well. Same thing with the ascites. Lots of false negatives. It might be too small to detect. And evolving injury. A lot of times you might do the fast and it's completely negative because maybe there's only 100 cc's in the belly, but then they go to CAT scan and now there's more, and now the CAT scan reads it as much more blood. It doesn't mean that you missed it necessarily. It could be that they're actively bleeding and you're just a little too early. That does happen. It's not necessarily a miss. All right, so there's a couple probe options, which we'll go into more when we actually scan. Your curvilinear probe and your phased array. I would argue that the one on the left should be what you start with. It's the abdominal probe. It has a wider footprint, a little bit better resolution. So this is probably your first go-to. The phased array, the one advantage of it is actually the small footprint. It can sneak in between ribs. So if the Morrison's is a little high, or you're trying to get the cardiac view and you're just getting rib shadow and it's just in your way, you can kind of sneak in between the ribs with this. But it's a little less resolution, so start with the curvilinear one if you can. There wouldn't be an ultrasound lecture without physics. This is all of the physics of ultrasound summed up in one thing that we really care about, so I'm not going to bore with the details. But just some of the terminology, when I start going through things, I'm going to use it. Basically, the ultrasound sends a signal and then listens back for the what's coming back at it. And it can tell what structure it is depending on what the characteristics are of that signal coming back. It's all shades of gray. We call isoechoic, and we define it. We define as isoechoic as the appearance of a normal liver on ultrasound. So we compare basically everything to what the appearance of the liver is. And so this is kind of a mid-gray. If it's brighter than mid-gray, we call it hyperechoic. If it's less gray, or so darker, we call it hypoechoic. And if it's completely black, then we call it anechoic. There's a couple of things that occur that I want to point out here. So when you have something that's hyperechoic, like let's say bone, like when you're doing the lung component of this, it absorbs all of the signal and doesn't allow the signal to pass through. So you get shadowing behind it, and that basically just obscures everything that's sort of behind what you're trying to see. And is why sometimes sneaking through the ribs is helpful. And then the other one is with the anechoic. So this is like you're trying to do an IJ, right? That's your blood vessel. So the bladder also does this too. It makes everything behind it bright white because it attenuates the signal. It increases what's passing through. It speeds up the process. It also creates a shadow on the edges. This is called edge artifact, and it's just because it's hitting the sides and it's trying to interpret that curvature and doesn't really know what to do, so it makes this false passage. Both of those things can also obscure your view, and I'll show you some examples of that. Sorry, I keep going through my computer. Yeah, right? All right, so the views. Typically, there's not really an order to this. Most people with blunt trauma are going to start in Morrison's. Other people advocate for doing the cardiac first, just because it's probably the most likely to kill you if there's a cardiac, pericardial effusion that's becoming tamponade. But typically I usually start with Morrison's for most situations. I usually I go right upper quadrant, then I do left upper quadrant, then I do suprapubic, and then I do cardiac. But again, there's not an order, and then I do the lungs last.
You said to try maybe starting with that bigger probe to start. Can you use that when you do the heart?
You can.
Okay.
Yeah, and when we practice, I'll show you. All right, so your right flank, right upper quadrant view. So there's really three things that we're looking for. So this is not a stagnant, look. It's not, you put the probe down and you just hold it there. You scan up, you scan down, you scan superior, you scan inferior. You kind of make a cross with it because you're not going to get everything in one view that you need to see. So you need to see Morrison's, all right? But you also want to trace the tip of the liver down, so inferior. The newest literature says that the most common place where you get fluid first, it used to be thought to be Morrison's, but it's actually now the tip of the liver, and then it kind of extends into Morrison's, is what the latest literature says. So if you have a very small amount of blood, that's where you're going to see it first. And then you can also scan superior and see the base of the lung, and that's where you're looking for a hemothorax. Okay, so this is where we start getting into clips. So again, this is your first view. Just to orient us, the probe is up top, okay, on the screen, and everything on the top is is superficial, and everything down here is deep. This is closest to the probe marker, and the other side is opposite the probe marker. This is your liver here, you have your kidney, and then you have Morrison's, which is right here. So you can see in this view that you can't get the entire Morrison's, because Morrison's extends this way. You also don't see the liver that extends this way as well, so that's why you have to scan down and make sure you're not missing fluid that's maybe sitting over here. All right, one more, sorry. Okay. So I did want to show this clip. This is a normal. It's gonna be so hard to do, guys. All right. You guys see that? I'm sorry. This is not ideal. I know. So again, kidney, Morrison's, liver. You see that the scanner starts up top and starts to scan down to get to the tip of the liver, which is right here. You guys see that? Mm-hmm. This is normal. This is what you see. You see a bright white line that goes in between liver and kidney. And let's go to here. I'll just point this one out because this one you don't necessarily need the clip for. So again, you have your kidney here, right? Liver is here, and now you see this anechoic area in between the liver and the kidney in Morrison's. So this is a positive fast right here.
That's in Morrison's, you said.
This is in Morrison's, yeah. It's extending into the tip of the liver as well. You see that?
Yeah.
Okay. Let's see if I can blow this one up too. Here, we'll play this clip. So you guys see, it even extends down here at the inferior pole of the kidney.
Yeah.
Liver, kidney, fluid.
So the anechoic is the fluid?
Yep, you can actually see at the very end there, you can see the liver kind of flapping a little bit in the fluid. See that up here? Wait for it. Yep,
Oh,
see that?
Yeah.
So it's basically submerged in fluid, so it's moving around a little bit. Sorry, I know this is gonna be annoying for you guys. I'm sorry. All right, here we go. Let's pull this one up. So first of all, just to orient ourselves, this is the same thing. Right upper quadrant. This is the liver. You might look at this. This is actually a false positive initially. This is actually the gallbladder. So if you're scanning very anterior, you're going to catch the gallbladder. Sometimes when it's collapsed, it can look like free fluid. When they scan through, so if you just looked at this, you might say negative, that's the gallbladder. You might call the gallbladder as positive, but it's important to scan through it because you'll see the difference when you scan through. You'll see that now there's fluid there. You see that?
Yeah.
So that's actually Morrison's. Now that's the free fluid.
The gallbladder's kind of underneath there,
The gallbladder is actually it's anterior.
but kind of down when he's
Yes.
moving the probe. Yeah.
Yes, exactly. See it coming right there.
That's the
gallbladder.
Yeah, then just for a
Yeah.
second you see it. But there's free fluid here, there's free fluid up there. Same thing, so this one you don't necessarily need the clip as well. So this now you just kind of scanned a little superior. So you have kidney here. This is Morrison's right here. This is the bright white line in between liver and kidney, bright white line. This bright white line over here is actually the diaphragm. And if I play this video, you can see that the diaphragm is going up and down as the patient breathes. This is a hemothorax, or presumed. It could be a pleural effusion, we can't say for sure, but this is free fluid. The reason we know that is using some of the artifacts of the machine and how the machine works. But if this was air within the lung, the signal would drop out right when it met the lung here. This bright white structure in the back here is the spine. Now the spine's obviously always there, but it would stop, it would appear to stop here, and you would have no white going forward. And that's because the signal just gets sort of trapped right when it gets to the surface of the lung. But because there's fluid here instead of lung, it transmits the signal all the way through, and now you can see the spine. So this is called the spine sign. So if you see this, the base of the lung, it means that there's fluid within the lung.
So when you're looking at Morrison's clip,
Yep.
like is that considered a lot of fluid, a little bit?
It's a good amount.
Okay.
You
At
mean
least
the first one or
200,
the second one?
250.
What's that?
No, that's probably a lot. That's probably closer to 500 or so. Yeah, that's a lot. That's a lot of fluid. All right, so there's definitely some pitfalls. I mentioned a lot of these. I'm going to kind of gloss through these just in the interest of time, but there's a lot of false positives. You might get something like this, that it's not quite anechoic. It's more of like a mixed gray. That's perinephric fat, and sometimes can be confused as free fluid. This one, I'm not sure what they're, I have to click on it. Hold on. All right, I'm just going to skip through this part. Okay, that's what I wanted to show. So the hepatic vessels, so this is a hepatic artery or hepatic vein, can sometimes be confused as free fluid. It's really hard to see here, but sometimes they can be big, especially if they're dilated for various reasons. And it can look like free fluid, but it's very circumferential. It looks like a blood vessel rather than sort of the irregular shaped free fluid. All right, so left flank, essentially the same thing on the left side. The only thing to add here is that fluid can also sometimes accumulate in between the diaphragm and the spleen. Where on the right side, you don't usually get that. So you do need to make sure that you see the spleen and the diaphragm, that interface. But same thing, splenorenal recess, tip of the spleen, and then the lower thorax. This one is normal. Here, I will play this. I see that. So same thing, kidney, this is the spleen up here. Like I said, you can sometimes get fluid up around the diaphragm over here on this side, right here is the diaphragm. You can sometimes get fluid, you'll see it on the next clip. But then this is the splenorenal recess right there. You guys see that or no?
Mhm.
Okay. All right, this one is a lot of blood. More than the last one. So this is spleen here. you can just see all of this anechoic, all of this black around it. You can even see, so this is kidney right here that pops up at the end. You see all of this. You can even see something within, which is, in the setting of trauma, would be like a clot. We also sometimes see this with like SBP in your cirrhotics. But you see basically stuff floating and flapping inside the ascites or the blood.
If you had like a shattered spleen, like a grade 4 or 5, would you see any of that?
You mean like this?
Yeah, like that.
Yeah. So this is actually the coolest one. This is like for extra credit, like mic drop, like done. You know. So this is spleen. This is like the normal echo texture, right? That isoechoic area. But you just got this basically disruption in the normal architecture of the spleen that goes right through it. You see this? This is pathognomonic. There's nothing else that looks like this. There's a clip associated with it, so I'll show you. It does. Is it working?
I saw something here too.
So you can see that there's now anechoic, and there's some hyperechoic stripes that kind of breaks right through the echo texture of the spleen.
There's a couple. It's pretty sweet.
Yeah, so that's you can see solid organ injury on ultrasound. It's not perfect. You're not going to see most of them, but when you see it, you kind of know what's going on. It's just a nice finding to point out. Pitfalls, basically the same as it was on the right side. The one thing though that I want to point out is the stomach. The stomach gets in the way all the time, especially if they've been bagged, they were intubated. There's a lot of air in the stomach, or if the patient had a bowel obstruction or an ileus, something like that, and they got hit by a car. The stomach can get huge and it can obstruct your orientation, so you can't necessarily see. So this is actually where you're looking, splenorenal recess here, in between spleen and kidney, but it's so pushed down because of the stomach. So you just do the best you can. You might have to change your position, change your probe orientation, maybe turn the probe to try to see what you need to see. But this is going to be a limiting factor. Maybe ask, I guess, us or to put in an NG tube if they're intubated. That would really help as well. Okay. Pelvis, rectovesical pouch in males, or the rectouterine, the pouch of Douglas in females. Okay. This one you're gonna have to look on here. Okay, so this is normal. I'm gonna stop it as we go, but this is the bladder coming in over here. This is all bowel with all shadowing over here. You can see as we scan through the bladder, you're looking for basically fluid around the bladder. There is a couple of things in here though that I do want to point out. See when they come in. Boom. So do you see how there's something here? It looks like there's a stripe of fluid. This is also a false positive. Something to keep in mind. This is probably the bowel wall. The seminal vesicles also come through here, but this looks more like the bowel wall. It has two sides to it. It's very linear. It travels in a very straight line, which when you play the clip, you can see when the scanner scans through it, it travels in a very straight line, whereas free fluid is going to be more irregular. If you see that, you just have to kind of scan through it and see, but a lot of times that's called as positive when it's not. The other thing I want to point out, you can see it here. So the bladder is one of those organs that because it's filled with fluid, it's going to cause that attenuation behind it. It causes behind it to be very bright white, which if you have free fluid that's back here, you may miss it because it's just so much brightness. So in that case, you may want to turn down the gain, turn down the brightness on the machine. You may want to reposition. You may want to scan in a couple different planes to make sure that there's no fluid that's hanging out here. And this is a positive pelvis. This one also you guys should look at too. So this is a female. You can tell because I'll show you the uterus comes in. Hold on. Let's go back to here. Good. So that's the uterus here. It's the endometrial stripe is right in the center. And then this is kind of your uterus. It's kind of crashing on the bladder. This is free fluid surrounding the uterus here. So this would be positive as well.
Yeah.
Yeah.
Hmm?
The dark stripe, right?
Yep, and you can also see it up there. As we scan through, you'll see it popping down here as well. Right there, see? Again, in a menstruating female, this might be normal. This might be physiologic fluid. I think that would be kind of a lot, to be honest. I would be suspicious that there's something else going on. But again, it could be a ruptured cyst or just physiologic fluid. Okay, we kind of talked about all of this already. I'm going to speed through this a little bit. Cardiac, most of the time we're doing subxiphoid, but half the patients we get are heavy. Maybe they're in a lot of pain, and trying to push to get that subxiphoid can be very difficult. So what you can do instead is a parasternal, where you just kind of put the probe in the 4th or 5th intercostal space. I use this probe. You don't need to switch to the cardiac probe. You can usually see what you need to see. But if you're having a hard time getting through the ribs, you can switch to the phased array.
This sounds cooler.
Phased array, I know. This is normal. So this is a subxiphoid view. So you know that because this is the liver up here again. So you're kind of getting the tip of the liver when you're shooting through. The first chamber that you hit is the right ventricle. Then you have your left ventricle down here. So this left atria, and this is the right atria right here. So you're looking at the pericardium, which is this bright white line that goes all the way around down here. Okay, and you're looking for fluid in between. This is obvious, I think, anyway. Again, this is your heart down here. And then you get this black stripe going across the top and down. So that's a pericardial effusion. See that? Cool. Okay. There's one thing to keep in mind. It's very common. At least half the patients that we see are going to have some sort of epicardial fat pad. It's only on one side, so it's not circumferential around the heart. And it's not completely black. It has some mixed echogenicity to it. It has some bright white areas. It usually tapers toward, it's larger here and tapers towards the apex. And it doesn't move. It doesn't change size with, during systole and diastole. It just stays the same size. It's a normal finding, but again, a false positive. Okay, lung, looking for lung sliding. One view on each side, and you can switch to the linear probe if you want. When you get comfortable doing it with the curvilinear, you can just use the curvilinear. It's just everything's going to be much smaller and just at the top of the screen. But it's perfectly fine to switch to a linear probe for this. And I'll show you what that looks like. So this is with the linear probe. So you have a rib here, and then all the shadowing that goes down here, because it's bone. Okay, rib is here, with all the shadowing going down here, and then this is your pleural line. Everything behind here, it actually doesn't exist. It's just artifact created by the interface between the fluid and between the visceral and parietal pleura, and then air in the lung. So that interface creates what's called A-lines. So these are A-lines going down. They don't actually exist. All right, they're just reflections of the pleural line.
And the pleural line's the bright white one.
Correct.
That was the first one.
Yep, the first bright white
Yeah.
line.
Right.
Mm-hmm.
And then the little dark stripe all the way above it.
What do you mean? Up here?
No, down. Right above right there. Yeah, that
Here?
whole line, yeah.
This is subcutaneous tissue. So this is, so you have skin,
Yeah,
so
yeah.
you have your intercostal muscles, fat, etc., and then you get to your pleural
I guess
line.
the one that goes, I'm thinking like across the whole thing.
Where? Let me see where you're looking.
Come on to the front of the class, please.
This, all the way across. That's still just
Yeah,
fat.
exactly,
Okay.
exactly. In fact, this is probably artifact. When you scan through this will probably go away. Because you got bone here, and so the signal is kind of coming down this way, and it's blocked, but the way the probe works is it also sends signal on an angle, so you get a little bit that's coming this way.
Yeah.
So everything that's behind this bone, which is right here, doesn't really exist either. Let me show you this one, because this one's pretty cool to see. I'll show you this one. So this same thing, we're looking at pleural line. It's a little bit of a different picture, but so you're looking for sliding. You're looking for movement of that pleural line. You see how sometimes it's referred to as like ants on a log,
Yeah.
or basically just movement.
So when you hear people say, oh, there's the lung, it's not really the lung, it's the pleural line.
Correct. You can't see the lung. Everything that you talk about with lung, you're referring to an artifact created by the machine that tells you what the appearance is of the lung. So you're not actually seeing the lung. It's an indirect kind of way of looking at the lung. But that's what you're looking for. You're looking for movement versus pneumothorax, where you just don't see any movement. Like, assuming the patient's breathing, there's just no movement, right? Nothing's happening.
I would have never known how to look for a pneumo.
I would never know either.
We'll play with this when we do the scan, because it's very easy just to hold your breath and then you see that there's no lung movement,
So is this like an all or nothing, or based on how big the pneumo is, or?
So for our purposes, for FAST, it's just, is it there or is it not? There are ways to quantify how large it is, which I'm not sure how useful that is.
Will you miss a smaller pneumo, or if there is one, you'll find it?
No, you can definitely miss small pneumos. When they've studied this in the right hands, it's about 90-95% sensitive, and again, about 90-95% specific. So it's very good, but small apical pneumos you might miss.
You shouldn't miss a pneumo that needs a tube.
Correct.
Okay.
You shouldn't. Yeah, you shouldn't, because it would be large enough that you would see it. There are some pitfalls to lung ultrasound, especially with this. So if the patient's right main stem and they're bagging them and you're not getting any movement on the left, it might not be a pneumo on the left. It might be because they put the tube on the right side. So they may want to reposition the tube. A bleb, so someone with COPD who has a bleb, you're not going to get lung sliding at that spot.
If the blood is right underneath.
Right underneath the probe, right where you're scanning. It'll look like a pneumothorax. There's nothing moving, but it's just that you're scanning over a bleb.
Would you see the contour or any indications of the blood if you were sliding around that blood?
Yeah, so again, this is a little bit harder to do, but there's something called a lung point. And this is kind of what you're always searching for when you have the time, but for the purpose of trauma, it doesn't really matter. But you can see an interface where you have that pleural line, and you can see that half of that pleural line is moving, and the other half of it is not moving. That interface between the two is called the lung point, and that's where the pneumothorax starts. So that's where you have normal lung that's sliding and no sliding. So if you have a bleb, it would be the same thing. You would have no sliding on one side and sliding on the other.
So you just slide down the lung until you find where the ants on a log starts, and then that's like your point? Is that what you're saying? Or?
Yeah, but the lung point might be anterior, it might be here, it might be posterior.
So what I'm hearing is confirmatory chest X-ray is a good idea.
So just, remember the context of this. It's you're looking for an unstable, someone who needs a chest tube now or needle decompression now.
Right.
It's somebody who has unstable vital signs, who you put the probe down and you say, yeah, they have a pneumothorax, let's decompress them, before you get the X-ray in. But the patients who are stable, it's cool to know if they have a pneumothorax, but you're still getting a chest X-ray.
Yeah.
You know what I mean? Exactly. So a lot of these other things looking for this and that, it's cool, but I'm not sure how clinically relevant it is for this purpose here. Pleurodesis patients who've had a resection, people who have lots of adhesions, again, you might not get lung sliding. It's another
The next trauma comes in and they have a normal chest X-ray, but then they have like a small pneumo on CT. That'd be the patient you break this thing out on and start looking for that.
Take a look. If you look at the numbers for chest X-ray is not very good for pneumothorax either. All right. Real quick.
The nurse is probably just all they're like, oh yeah.
Last thing, and then I'm done, I promise. Just remember these couple of things. The indications we talked about, there's a lot of times that we're not necessarily going to need it, or it'll be, of any use. For our purposes here, we're just trying to do more so that we get better at it. but it shouldn't delay CAT scan, especially in someone you think has a head bleed, you know, and no other injuries. Maybe the fast isn't what you need to do at that time. Not all fluid is blood. Not all black is blood or fluid. It could be, you know, bowel, you know, within a vessel, etc. And you can see the numerous amount of limitations that we talked about. So, anyway, any questions about any of this stuff?
Yeah, thank you.
I'm sorry that the clips didn't work. They're looped, so as I'm talking, like you know, you can see them, and I don't have to keep clicking them, and you can actually see them. So
Total letdown.
yeah,
We'll have them figure something out.
figure something out. Yeah, in the future we can maybe figure this out. I just did it. I didn't realize. I didn't know, and I apologize. My computer is also a little older, and the PowerPoint doesn't allow to do presentation mode on here, which is another issue too. So
Yeah.
anyway,
Yeah, no, it was good.
Yeah.
questions, or you guys just want to get scanning?
Just scanning.
All right, let's do
All
it.
right, can